Let's dive right into this explainer, grab our magnifying glasses, and become clinical detectives. Today, we're going to crack the case of acute kidney injury. We're literally mapping out exactly how this condition happens, the absolute physiological chaos it unleashes, and most importantly, how we can step in and fix it.
To solve this mystery without getting totally lost, we're using a 3 buckets framework. We'll quickly define the injury, then evaluate our 3 buckets: prerenal, interrenal, and postrenal. After that, we'll look at the dangerous complications and finally lock in our diagnosis and treatment plan. Let's get to it.
Right, so we first need to identify our crime scene. We define acute kidney injury fundamentally by looking for an abrupt failure in the kidney's main job, which is filtering waste from the blood and making urine. It's that sudden drop in urine output paired with a sudden spike in serum creatinine, that waste product the kidneys are supposed to clear out, that really sets off our clinical alarm bells.
And the good news? We don't have to guess. The KDIGO guidelines give us very strict quantitative metrics to confirm this injury. Basically, you've got AKI if you see a critical drop in urine output, specifically less than 0.5 cc's per kilogram per hour for 6 or more hours. Or you can look at the blood work for a sharp spike in serum creatinine. We're talking either a bump of 0.3 milligrams per deciliter within a strict 48-hour window, or a jump to 1.5 times the patient's baseline within 7 days. Hit any of those markers, and yeah, the kidneys are failing.
Okay, moving to section 2, prerenal, focusing on blood flow, or what we call the dry hose.
Our first bucket of suspects is prerenal AKI. I want you to think of this entirely as a plumbing problem. It's like the physical hose supplying water to the kidney has just completely run dry. As you're investigating your patient, keep this in mind. A staggering 60 to 70% of all acute kidney injuries fall right here into this prerenal category. Because it's your most likely culprit by far, any drop in renal perfusion, meaning a drop in the actual blood flowing into the kidney, needs to be your very first suspicion.
So how exactly does this blood supply dry up? Well, the most common way is through severe hypovolemia. The patient simply lacks the fluid volume in their body to push blood into the renal artery. You can easily remember these massive fluid loss triggers by the 3 Ds: diarrhea, excessive diuresis, and dehydration. Oh, plus our honorable mention, severe blood loss. Simply put, if the tank is empty, the kidneys get starved.
Now, this is really fascinating. It's crucial to realize how a completely different organ can actually be the mastermind behind a kidney injury. Take cardiorenal and hepatorenal syndromes, for instance. With a failing heart, a drop in cardiac output means less blood pushing into the kidneys. Or, with a scarred cirrhotic liver, systemic vessels dilate so wildly that blood just pools elsewhere, which drastically reduces the effective arterial blood volume reaching the kidneys. In these cases, the kidneys themselves are structurally perfectly fine, but they are desperately lacking that essential blood flow.
Next up is section 3, intrarenal. This is all about the internal damage, which we can think of as the broken filter. The second bucket happens when the blood supply coming in is actually totally fine, but the physical filtration machinery inside the kidney itself is broken. The absolutely crucial point here is recognizing acute tubular necrosis, or ATN, because it accounts for a massive 85 to 90% of intrarenal cases. Basically, the kidney's internal tubular cells die, slough right off the walls, and physically clog up the microscopic tubules. If you look at the patient's urine under a microscope, these clumped dead cells form what are classically known as muddy brown casts. Seriously, if you see muddy brown casts, it's pathognomonic for ATN. But who or what breaks the filter? Well, these broken filters are usually caused by some known nephrotoxic suspects. We're talking about heavy-hitting antibiotics like vancomycin and aminoglycosides. We're talking about IV contrast dye used in imaging, and we're also talking about massive cellular breakdowns inside the body. Think of myoglobin tearing through the tubules during rhabdomyolysis, or uric acid crystals just shredding the cells during tumor lysis syndrome.
All right, moving on to section 4. Postrenal, focusing on the backflow blockage, aka the clogged drain. Now, in this scenario, the blood flow and the internal filters are actually perfect. The problem is a clogged drain further down the urinary tract. Let's watch how this builds mechanically step by step. Say an obstruction forms, maybe it's a kidney stone or an enlarged prostate. Urine physically backflows up the ureters. All that fluid buildup creates immense pressure inside the kidney, known as capsular hydrostatic pressure. That built-up pressure literally pushes back against the incoming blood and bam, it effectively shuts down the glomerular filtration rate.
Which brings us to section 5,
the dangerous complications.
See, identifying the bucket is really only half the battle. Once the kidneys are injured across any of these buckets, the patient is at immediate risk for severe collateral damage. Our kidneys manage the body's balance, and without them, absolute chaos ensues. Patients typically progress through a specific timeline here. They start in the highly dangerous oligoelp phase, where urine output drops and lethal toxins just build up rapidly. If they survive that, as the kidneys start to heal, they enter a really risky polyuric phase. This is characterized by massive urine output that can easily cause severe dehydration. And finally, they enter a recovery phase, which honestly can take months to even years.
During that initial, super dangerous oligaric phase, the absolute most terrifying complication is hyperkalemia. The inability to filter potassium out of the blood causes a severe, lethal spike. This toxic level of potassium physically alters cardiac conduction. If you're watching the ECG monitor, you'll first see these sharply peaked T waves. Then those devolve into lengthened PR intervals, AV blocks, a widening QRS, and finally, the one we all dread, a deadly sine wave pattern that can trigger a cardiac arrest right in front of you.
Another massive complication during this phase is uremia, which is a highly toxic buildup of blood urea nitrogen. And uremia attacks multiple organ systems. We're talking severe brain confusion and lethargy. It triggers asterexis, that bizarre flapping hand tremor. It inflames the heart lining, causing pericarditis with a very distinct chest friction rub. Oh, and it even breaks the body's platelets, making the patient highly susceptible to random bleeding. It's a total systemic meltdown.
Finally, Section 6, Diagnosis and Treatment. It's time to solve the case.
Now that we've gathered all our clinical clues, we need to map our patient's symptoms directly to a cure. If you're ever stuck between buckets, we use a brilliant lab metric called FeNA, the fractional excretion of sodium. Think of it like a tiebreaker. A low FeNA, less than 1%, means the kidneys are desperately holding on to sodium and water because they're starved of blood flow. That proves a prerenal AKI. But a high FeNA, greater than 2%, proves the internal tubules are dead and broken. They are completely unable to reabsorb sodium, which firmly points us to an intrarenal ATN.
And here is where it all comes together. By matching the exact bucket of AKI to its specific clinical fix, you can basically reverse the underlying mechanics of the injury. Got a dry prerenal hose causing hypovolemia? You rapidly administer IV fluids. Dealing with an intrarenal broken filter? You immediately stop all nephrotoxic drugs and provide supportive care while the cells regenerate. And for a postrenal clogged drain, like a distal bladder obstruction, something as simple as inserting a Foley catheter can instantly unclog the system and save those kidneys. But, of course, we always have to be ready for the worst-case scenario. If our specific bucket fixes fail and the patient develops untreatable refractory metabolic acidosis, deadly refractory hyperkalemia, severe fluid overload that's drowning their lungs, or severe uremic complications like brain swelling, well, we have to bypass the kidneys entirely. We insert a central venous catheter and initiate emergency hemodialysis to artificially clean their blood. It's our absolute last line of defense.
Acute kidney injury is a high-stakes puzzle for sure, but as we've seen, it follows strict physiological rules. So the next time you face a patient whose kidneys are abruptly failing, ask yourself, which of the three buckets is the true culprit here? And exactly how fast can you fix the plumbing before time runs out? Thanks for diving into this explainer with me today. Keep investigating, and I'll catch you next time.